Welcome everybody to the first Think Global of the semester. You returning students, we are so glad you're here. And in first years, this is one of the best parts of is you guys. There's so many of you here today, so thank you for coming. I'm excited to be moderating this panel. My name is Emily Smith. I'm an epidemiologist here and in the Department of Emergency Medicine, and I also have a new role of faculty liaison between our partnership at the University of Global Health Equity in Rwanda. There's a lot of either existing or want to be partnerships throughout Rwanda. You're going to hear that today in the panel for sure, but it's a nice new endeavor. It's a bubbly endeavor is what it feels like. So there's a lot of momentum behind it, starting with today. A few logistics before we get going. Today's session will be recorded and posted publicly, so that's important to know for comments and questions may be seen by others. Also, we will have time for a Q&A, hopefully some really great times for Q&A, and we would welcome questions from both the in-person audience and those of you online. And post that and we'll monitor those. So I'm delighted to introduce today's panelists for sure. I'm going to give really brief introductions. We can take the whole time with doing their real work and introductions. If you want to know more, it's on the event website. They're full biographies. Our program today will begin with a short talk by Dr. Vanessa Mondera, who's here at DGHI. He's a visiting scholar with Gavin's group at the Center for Policy Impact and Global Health. He is the executive director of Society for Family Health. That's the largest nonprofit in Rwanda for primary care. Following his presentations, we're going to hear from three other panelists who have research and capacity building projects in Rwanda. One is Barnabas Aliambe, who is online. See him. He's a friend of mine. If you take my global surgery course that I co-teach here with Henry Rice, he is the co-teacher of that from UGHE. He is a specialist general surgeon and assistant professor of surgery and co-chair of the Center for Equity in Global Surgery in Bukaro at UGHE in Rwanda. Maggie Conlon is a current second-year MSGH student here at the DGHI, who recently traveled to Kigali, Rwanda, as part of her master's thesis work. So share a little about that. And then Dr. Eleanor Stevenson is a clinical professor of nursing here at Duke, right across the street, the School of Nursing. Her area of research focuses on the multi-dimensional psychological stress of women who have conceived pregnancies via in vitro fertilization experience, as well as the adaptive behaviors of men with male factor infertility. So what we're going to hear about today, I love the title of this global health project that we're doing right now, Climbing 1,000 Hills. And when I was thinking about this title, I think it can be interpreted as the beautiful land of Rwanda is a land of 1,000. It's just gorgeous. Also, in global health, we climb 1,000 hills, which can be hard work and also doable. You are going to hear that today for sure. I think we all know about the 94 genocide that happened in Rwanda, and 80%, over 80% of the hospitals were destroyed during that time. The Ministry of Health from Rwanda has spent significant effort to rebuild through partnerships with policymakers and stakeholders. One of those is the Society for Family Health. It is the largest nonprofit provider of primary health in Rwanda with more than 300 health posts that I'm sure we're going to hear about. So we are thrilled that you're here today to share with us about your work.
Good.
Thank you.
Yeah, thank you very much. First of all, I feel absolutely honored today to be sharing with you such an incredible audience, both here and online. Like she said, Manasseh Wandera is my name. I serve Society for Family Health as Executive Director. We are operating in different African countries, headquartered in Rwanda, having worked in South Sudan, Central Africa, and DR Congo, and we are actually spreading our wings across the African continent to replicate what you have seen succeed in Rwanda in the area of primary healthcare. So today, I'm very delighted to be speaking about the title that she just talked about, fixing primary healthcare, the case of Rwanda, using small clinics, which we call health posts in Rwanda. But just to give you a bit of history, like she read, in 1994, our country experienced the worst catastrophe in humanity, the genocide against the Tutsi. Over 1 million people were murdered in just 3 months. And we lost almost everything. The health infrastructure, the economic infrastructure, the whole country ran down. I think it's part of what she was reading. It is a global knowledge that this is the worst genocide ever. So to revive from that took lots of efforts, of course, under strong leadership that is very committed. And I feel privileged and honored to be part of this journey, especially around the healthcare in the area of primary healthcare. And we realized that apart from Rwanda, of course, the world has, as we know, there are lots of political instability, there are lots of environmental disasters, lots of poverty, and a lot of other geopolitical factors that really affect healthcare. And this is where the role of primary healthcare plays a big role, and specifically facilities that one of them that you can see on the screen, the health post. So the government of Rwanda has set up a policy in the effort to rebuild the country to make sure that each household should not walk for more than 30 minutes walking distance to get to healthcare. Because previously, and even now in the areas where there are no health posts or health facilities, people have to walk for over 6 hours, 3 hours, minimum of 3 hours. So you can imagine, even when you're in perfect health, to walk for 3 hours, but imagine if you're walking for 3 hours when you are sick or when you are pregnant. And like she perfectly described Rwanda, a land of 1,000 hills, and we normally add millions of smiles, but those hills, climbing those hills when you are sick or when your health is not in perfect shape becomes a big problem. So we are coming from a situation that really, for lack of better word, that has seen so much. But thanks to the government of Rwanda, thanks to partners, and thanks to my organization too, that is partnering with many other organizations to fight this fight to achieve universal health coverage and overcome the broken system. So, in rethinking primary health care, we really have been approaching this effort not as an event, not as a partner, but rather as a system. Wanted to look at it. In the last 7 years, we have been trying to look at the primary health care as a system of interconnected parts. Because previously, and in some other cases, we look at some interventions working in silos, working as events, as interventions, as projects. But we realize that actually, if you look at it as a system, you can be able to achieve significant results. And sometimes we realize that global health often treats problems in isolation. And people are addressing poverty and safe water, malnutrition, and the other things. But when you look at the community as a whole, then you realize that actually you need to address it as a system. So We know that there are several health determinants that are actually the root causes of poor health, just like I was describing, lack of clean water, poor sanitation, malnutrition, poverty in the areas, in the rural areas, and weak infrastructure. So at Society for Family Health, in partnership with government, we decided to look at the whole system and address each of them using a framework of WHO of 6 building blocks. So number one, we looked at the recurring patterns and we decided to address limited access to care. That's how we came up with building the health facilities. Then we started tackling healthcare workforce shortages by systematically training health workers, giving them the relevant skills, and deploying them with continuous supportive supervision. Then the issue of medicines. So we partnered with Rwanda Medical Supply to make sure that we can have reliable medicine supplies in all the rural areas. And then the data gaps, because we believe that you can have everything, but if you don't have the right data at the right time, you can have challenges. So we are now working with different partners to ensure that we have reliable data, real time, to make informed decisions. And we are working with the Rwanda Social Security Board, which is a government institution that is supporting in providing health insurance to make sure that there is significant financing and equitable financing, and of course, improving the aspects related to governance. So maybe if I can just dive in deeply. So maybe this one I can just read it. Looking at the issue of access. Currently, we have been able to work with the government and we have built over 300 and actually the latest numbers now is 350 health facilities across the country, interconnected health facilities. And this has solved problems of access. People who used to work for 6 hours, for 3 hours, for 4 hours that I was talking about earlier, can now take a maximum of 30 minutes walking distance and they can receive care. But when they are there, they need to be received by trained healthcare workers. So far, we have trained over 10,000 healthcare workers who are working in these facilities and in the communities to support and to be able to provide care. Just in terms of context, each of those facilities that you can see in the diagram serves between 7,000 to 15,000 people in the catchment area. And those are people who otherwise would have to walk for long distances. And when they come, they are received by trained healthcare workers with skills, with good attitude, and with empathy, who treat them with empathy. And they know that they can go back and go back to their gardens and do their day-to-day activities. So we have realized that actually health posts or health facilities without trained health workers, they're like empty shells. So that's why, on top of training healthcare workers like in the field, we are actually coming up with a healthcare workers academy that is going to be like a launch pad for training, retraining, upskilling, and also kind of refresher training to provide continuous skills. It is a common statistic that is actually alarming that Africa actually has about 42% of the professionals are leaving, which costs, which leads to over 1.8 million lost in per worker. So that means that without properly trained individuals, even if you solve the problem of access, you are actually losing people, and those who get trained without real support, they just leave the continent. So our goal is to have this academy connected to the facilities and make sure that there is an interconnected ecosystem. Yeah. So earlier I talked about our partnership with Rwanda Medical Supply. Previously, when we had these facilities, it was very difficult to have the medicines available. Now, with our partnership with Rwanda Medical Supply, we have access to medicines to the facilities in a very real-time way. And we use technology to make sure that we are able to know when we have stock out, and we are able to predict and stock these facilities in time. We also use social marketing, for example, to distribute products like condoms, family planning products, water purifiers, to make sure that the people in the communities can access them real time. So tech really helps us a lot in terms of making sure that we have the facilities, we have the products that are needed at the facilities in real time. So, yeah, thank you very much. I think I have preferred to take you to the field, but maybe just before I show you a quick video, we pride ourselves in the power of partnerships. Our partnership with the Rwanda Social Security Board, with the Rwanda Medical Supply, has really helped us to ensure that the 350 facilities that we run are timely reimbursed. So actually, in Rwanda, over 95% of the population have health insurance. So if you solve the problem of health facilities, if you solve the problem of healthcare workers, then you are sure that the government is going to provide insurance, which makes it really very easy. And so our partnership with the Rwanda Social Security Board and Rwanda Medical Supply has played a big role. And the best of this program has been that all these facilities are run by nurse entrepreneurs, which really makes it very sustainable. Because once you have the facility, once you have the trained health worker, now it can roll on its own. So without taking much time, I want to invite you to the field by watching a short video, about 7 minutes video, see exactly what is happening in the field. Thank you very much.
Systemic barriers to health and dignity are the root cause of suffering across the continent.
Our work at Society for Family Health is actually beyond providing health care. It is not just providing health services. In my heart and in my mind, it is providing dignity. The fact that we are reaching millions of people with clean water, with hygiene products, with disease prevention products, with hundreds of health facilities, training health workers, to me it is actually living my promise.
Dignity begins with access. Health cannot be a luxury. But what is a right if you cannot reach it? That is the question we answer every day. For the 57% of Africa's population in rural areas, this is the reality of health inequity.
Ntabwo dutegereza, turubaka, ntabwo twubaka gusa, ahubwo dufite isezerano ku baturage bose, kubavura tukabasubiza agaciro kabo.
A building is empty without people. The WHO warns of a 10 million health worker shortage. But we see Africa's youth, 60% of the population, as the single greatest asset to solve this crisis.
Ntabwo ndi umuforomokazi gusa, ndi rwiyemezamirimo, ndi umuyobozi, SFH ntabwo yampaye akazi gusa. Yanyongereye ubumenyi, yagura inzira y'umwuga wanjye.
In the pipeline, we have Africa Healthcare Workers Academy, a gateway for talented and skilled healthcare workers that are really going to transform this continent with young people with the right skills, with the right tools, with the right mindset to be able to shape the whole of Africa's healthcare. In fact, we strongly believe that we're building a generation of healthcare leaders from the ground up that is going to transform this continent. Imagine a health system whereby over 90% of its health supplies and medicines are imported. Basically, you have no control. So, this is not only a supply chain problem. Actually, it is far beyond. It is complete breakdown of healthcare. It is a broken system, and this can be fixed. So what we are doing with our partners, what we are advocating for, is actually having local production of medicines, having the capacity. I strongly believe that if we put our minds together, we can have the medicines we need in-house or in a country.
Hope should not be imported. Our model is different. We use social marketing to create demand and build trust in affordable and quality assured products. Then we empower local entrepreneurs to build decentralized, community-owned supply chains to deliver them.
Okay.
We launched our Blue Room, connecting to our health post to a centralized data hub powered by EMR system, artificial intelligence, and satellite connectivity. We are moving from reactive storytelling to predictive population strategy. This is where cutting-edge technology meets the fertile ground of community needs.
Dignified healthcare should be affordable. Over 100 million people are forced into poverty every single year because of lack of capacity to pay. That's why at Society for Family Health, we have been lucky to partner with institutions like Rwanda Social Security Board, RSSB, Rwanda Medical Supply, with the support of the Ministry of Health, under the guidance of the government of Rwanda, to make sure that all our facilities that are run by nurse entrepreneurs are able to have their expenses reimbursed. It is no longer that healthcare is an expense sector. Now it is actually an economic engine, especially in the rural areas. So I believe this model and many others combined can break the chain of the issues related to health financing. Providing health care should not be looked at as a charity work. It is actually a strong business case, especially using blended financing and nurse-led entrepreneurship model. We have now over 300 clinics that are run as businesses. They have over 5 million customers, and they're making money and providing health services to people. So we have seen significant improvement in health outcomes and lots of employment. So many people are employed and lots of revenues being generated. At SFH, we do not only provide health services, we build leaders across all the levels. Leaders at the national level who help in the shaping of policy and really providing the input for policy formulation. We also build leaders at community level, like nurse entrepreneurs, community health workers, who really shape the actions, who coordinate, and who build systems that are trusted by the communities themselves. And there is strong accountability mechanism that is embedded and inbuilt, such that the health services that are provided, you can be able to assess and see the quality. You can be able to provide timely feedback, which is acted upon to make improvements. And these systems help us to make sure that they keep us on track, and we are able to replicate them to other communities. So really the concept of leadership and governance and accountability at SFH's interventions.
Thank you very much. I think in the next 2 minutes, I just want to tell you that this is a testament that when people work together, when you have intentional partnerships to solve a specific problem, things work. So the concept of nurse entrepreneurship that I was telling you earlier and that we are describing is something that I can say that we stumbled on it because we realized that even if we are able to build these facilities, you can build a facility, you can train people, but the component of sustainability was very challenging to us. So we had a conversation and it popped out that actually you can give these facilities to people under a contract to provide specific service package approved by government and tell them to run it as their own business. I am happy to report that over 70%, actually now 76% of these facilities are profitable. So that means that once you have done the initial investment and you have trained personnel and you're providing supportive supervision and you have built-in mechanisms to really get the medicines in time, get reimbursements in time, provide the capacity, then you have solved the problem once and for all. Margaret was there, she was able to visit us, she saw some of them, and we are so fueled and energized that we can replicate this model across the African continent. So far, we have these over 300 in Rwanda. Our goal is to take up to 100,000 across the African continent, but we believe that the strong capacity building through Africa Healthcare Workers Academy, strong supportive supervision, strong partnership with institutions like Duke, bringing in expertise and learning from each other can support this to be very sustainable. I want to thank you very much.
Oh, how do you follow that? Lovely. I just love the concept of helping families climb the hills in a holistic way that is more than one aspect of healthcare. It's a both and, plus poverty, plus maternal cares. I have a load of questions, but thank you for sharing that. Maggie, I can't wait to hear about your work, your thesis work this summer. So tell us a little bit about that, on the ground, and then specifically about understanding patient preferences and how to really target.
Yeah, so my work is a discrete choice experiment looking at patient preferences and healthcare seeking choices. So essentially what we're looking at, to go off of Manasseh, as they talked about the 30-minute distance to walking to health posts, what we're also looking at is to see if that solely is alone a factor to contribute to determine if that is enough for like someone to change or decide to go to a health post versus going to a health center, or if they're going to delay care because of distance. But we're also looking at attributes such as if they have access to appointments, or they're increasing NCD medications, or working on mobile versus fixed clinics, which are all things that I've spoken with Manasseh about that they're trying to sort of implement at SFH. So yeah, that's kind of a general overview of my work.
I love that. And then how did you, was that your first time to go?
Yes. Yeah.
So how was it seeing the country, seeing the interconnectedness that he talked about so much?
Yeah, I think he's not lying. Thousand Hills is very Thousand Hills. It was really interesting. I think it was also, I would love to highlight to see the amount of technological advances, and they're using drones to ship medications, and they're the blue room and tracking even just like the refrigerator temperatures, and then sending those back to the blue room and being able to like in real time contact the health posts across Rwanda, I think was really, really cool. And especially to see after the genocide and such like a historically horrible event, to be able to see sort of a country really come back and have so much pride for their country as well as for healthcare and really redeveloping. It's been absolutely fascinating to see, and it's really, really awesome and really cool, and a great example, I think, of beyond conflict.
Development. Yes. Oh, love that. Thank you, Maggie. I'm sure we have more questions, especially from students. You guys be thinking of what to ask specifically Maggie about thesis work. Barnabas, if I can come to you, you are there. You are in Bitaro, working in Rwanda, but you do not necessarily primary care, it's specialized care of surgery for children, which is typically found in the tertiary centers, not in primary care. But I know your heart, and I know you believe in this interconnectedness as well. Maybe speak to how that works from primary care to you doing surgery?
Thank you. I just want to appreciate Manasseh Wandera for that great talk and the fact that they have provided 350 of the over 1,200 or so of the health posts and 513 health centers. So maybe just to say something about or give a background about the health structure in Rwanda in an answer to that question, that Rwanda's healthcare system comprises 4 levels. So there's the community, there's the primary level, and then there's the secondary and tertiary care. But there is such a connection that at these primary care levels, 90% of the burden of disease is treated just at these levels, right? And so it's what either has escaped primary care or what has gone beyond primary care that is funneled to district hospitals, to provincial hospitals, etc. And so primary care is the key entry point for anything, surgical disease, surgical healthcare, looking at the 30 minutes walking distance. And because it's the primary entry point, if we don't pay attention to primary care, we get more complicated cases. Rwanda, because it's easy to, there's lots going on at the community, there's lots going on at primary care. It is a priority. And so we're able to catch things earlier and then pass them on to primary care. An example, for instance, we were in communities looking at the burden of disease, just walking house to house and identifying them. And rather than just take them straight to a tertiary facility, what you do is right there, you've got community health workers. From there, they walk to their health posts. What can be addressed there is addressed there. Whatever cannot be addressed there is moved on to secondary and tertiary levels. So I think that's the first thing, that primary care is essentially the key entry point for all healthcare within Rwanda. The second is the concept of decentralizing services. The health posts that are established, now there's some medicalized health centers that are being established. We've got 8 of them, and I think another 6 to 8 are being designated as we speak. And C-sections are going on at these primary healthcare level, right? So there are some things that can be taken down, including basic care, minor procedures, suturing, abscess, incision, and drainage, and things like that, that are surgery that are going on at these things that we will call primary care. And then there are people who are trained to identify surgical conditions and quickly send them up the ladder. And because primary care is strengthened, then you find that people immediately are able to identify this is surgical, this is something that needs to be referred, and then it is referred. And then there's this strengthening of referral systems. Many of the primary care levels will have some kind of ambulance or ambulance referral system that can pick patients from here and immediately, there's, based on improved communication, transport links, connect between the primary to the secondary to the tertiary facilities as they are needed. And again, on occasion, there is infrastructure that is used at the primary health level by surgical teams coming in, some kind of outreach, some kind of moving from the center to address things at the primary care level. So I think that there is this strengthening of primary care that was brought about as a solution to rebuilding, as one of the solutions to rebuilding the healthcare system of Rwanda, has actually set the ground, has prepared the ground for people to access surgical services in a number of ways. Over.
That's wonderful. Thank you, Barnabas. Do you want to respond? I saw you writing notes and shaking your head.
No, I'm very happy about Barnabas' points about the whole structure of healthcare in Rwanda. Like he said, at the base of the pyramid, at the community, we have community health workers, approximately 60,000 of those, who really go house to house, sensitizing people about healthcare, hygiene, addressing early signs of disease, and encouraging people to seek care early enough. And that has really helped a lot. But there's also another level, which is the health post, which are the ones I was talking about. And in Rwanda, the government policy is that at each cell, which administrative cell, which, like I said, has between 7,000 people to 15,000 people should have this health facility. And it is the policy of the government to ensure that nobody walks for more than 30 minutes walking distance. But in most of the cells, there were no these health posts. All those that were there were completely dilapidated and broken down. And that's how our partnership, our public-private partnership with the government of Rwanda plays a critical role to build the new ones or to rehabilitate those ones that are not working. So, like Barnabas said, over 90%, actually 93% of all the cases are at this level, level of community health workers or health post level. And now it becomes actually close to 96% if you add the health centers. So you can imagine that the bulk of the population burden, disease burden, is at the lower level, which we are addressing. So it is very, very important that we have the critical mass of trained health workers, as well as functioning facilities which are interconnected, enabled by technology, with easy supply of medical equipment and medicines and all the supplies, very much decentralized. And I am very proud of our partnership with the Ministry of Health of Rwanda, other partners, because this has significantly improved the health outcomes, especially around maternal child health and basically the other diseases that come as a result of poor hygiene. So to your point, if we address the breakdown in the primary healthcare, the community level, we will give people like Barnabas more time to attend to more severe cases at the hospital level.
Yeah.
Thank you very much. Yeah.
Wonderful response. It's
Yeah.
such a great segue to Dr. Stevenson, because people at that health post and the community centers are the heroes or the nurses that are there and can help identify some of these more complex cases or just treat. So I know you have the first of its kind in the country. You're involved in the University of Rwanda's DNP training program. It's the first. It's just incredible. Can you talk about a little bit of that program, your work at in Rwanda, and then anything to this discussion?
Yeah. Well, before I talk about that, I just want to address the training capacity around nursing. I mean, it's wonderful that you have the space and you need the people, right? And so I think what's been really wonderful to see the Rwandan government really be very proactive in thinking about all aspects to make sure that the care delivery is advancing to meet the needs of the population. And last spring, they instituted a 4x4 policy to train 4 times the number of nurses. And so our partners at the University of Rwanda School of Nursing have taken on this challenge. It's a big ask, but they're basically quadrupling their size of enrollment so they can have 4 times as many nurses to meet those needs. So the behind the scenes that is to be able to meet those needs, but it's going to take time because training nurses just takes time. And I think you mentioned before just about nurses or healthcare workers not necessarily staying in one location and other opportunities, drawing them elsewhere. And that is true in nursing. Nursing shortages are a global issue. Every country I visit, so I oversee our global and community health office at the School of Nursing, and we have partnerships all over the world, many schools of nursing, and I hear over and over again about the growing nursing shortage. And Rwanda is certainly not immune to that. And you're finding in, what we call brain drain, or people will get training and then they leave. So finding those opportunities through that nurse entrepreneur model is a brilliant way to be able to build capacity and keep the people that you need in the communities that they serve. It's specific to the DNP program. So our partnership with the University of Rwanda School of Nursing is long. We've probably been partnered with them for about 10 years. We have a lot of different projects we do with them. But again, with forward thinking, the government of Rwanda has identified the doctorate of nursing practice educational preparation as a way to address healthcare issues. So many may not know what that means. So I'll just give a little 60-second, what does a DNP mean? So a doctorate in nursing practice is a terminal doctorate. It's a clinical doctorate. So an advanced practice nurse could become a DNP as opposed to receiving a PhD to do research. DNP trained nurses are about quality improvement, implementation science, those sorts of have those sorts of skills so they can help implement evidence into practice and help move the needle on outcomes, health outcomes. And so it's a degree that we've been, we started in the US a couple of decades ago, success, and other countries are starting to replicate it because they see the promise of having these trained nurses who can identify clinical problems and address it at the local site. And again, Rwanda has been forward thinking, and to my knowledge, is the first country on the continent to say, we need this to help move needle. And so as part of that, the University of Rwanda is finalizing their curriculum, and they're specifically right now training advanced nurses in the pediatric and neonatal space, because those are the areas around neonatal mortality and whatnot. And so as part of that collaboration, we have 6 of the University of Rwanda instructors who are pediatric and neonatal specialists who are enrolled in our DNP program across the street. We do offer hybrid, so they're in Rwanda most of the time. And they are doing quality improvement projects at the 3 major tertiary hospitals in Kigali, both in the neonatal ICUs and the pediatric units. But with the idea that when they start to enroll their students, that they will have capacity to go beyond what these specific 6 will be trained in. So it's been a really rewarding experience to be able to work with the school on their curriculum and help guide these advanced nurses. I chair 3 of them, and they're all set to graduate in May. So
Yeah.
it's very exciting.
Excellent, excellent. There's so much to ask with this panel, and I want to do just that. I want to open it up to questions you may have. We certainly have some online, so feel free to continue putting that in the chat and I can monitor it. But anybody online want to start us off? Or in the room, as I look at you and say online. Yes, go ahead.
Hi, so I'm Hira. I'm a public policy master's student. Firstly, thank you so much for such an insightful and inspiring. It was really inspiring to see how Rwanda has worked through rebuilding the health system. I think my question is particularly around the data systems, and I wanted to understand the kind of challenges that were experienced when Rwanda rolled out the EMR system, the Blue Room system, and live tracking of everything, and especially how was facility level compliance ensured, and how was the facility able to transition from manual record keeping to a completely electronic system?
Yeah, thank you very much. That's a very, very good question. And I think it also gives me opportunity to speak more to the point that I kind of skipped because of timing. So one of the challenges is fragmented data. So it has been a very big problem, and we're trying to address it. Of course, this is the government of Rwanda passed established an institution that is in charge of data governance and compliance. So that means that there is a capacity building efforts that are going on, but we do not also have enough skilled people in data science and data management. Besides that, we also have different EMRs, and they need to be synchronized. They need to be interoperability between different systems so that you can have everything on the same screen, if I may say. So at Society for Family Health, what we showed there as our Health Intelligence Center was the first of its kind, whereby all our facilities are given training. First of all, we created the role at the facilities called Digital Health Officer, a DHO. So this is the person who collects data, who's first of all given training, given the tools, and collects data and is able to send it to our Health Intelligence Center. And then it is not just one direction. So in our Health Intelligence Center, we have teams who are trying to make sense of the data and support the nurses, but it is really at the infancy. So the issue of capacity, the issue of fragmentation, and of course, also the issue of power. We have recently partnered with Starlink to make sure that we can provide internet, reliable internet in the rural communities. But it also has its own challenges. So issues around the connectivity, skills, fragmentation, and generally being a new system, we're still struggling. But I'm happy to report that out of the 300 facilities, over 300 facilities, 126 of those are reliably interconnected. Yeah, thank you very much. Yeah.
As an epidemiologist who loves data more than anything else, thank you. Go ahead.
Yes, so once again, my name is US. I'm a first year master's in global health student. And congratulations, this is a very commendable work. One question, just for the sake of clarification, when you mentioned about healthcare workers, community healthcare workers, about 10,000 of them trained. I just want to understand, in the health posts that you're talking about, are community health workers working there, or are they working in the community, or who are working in those health posts that are spread all over the country? Because I'm coming from Tanzania, so such kinds of health posts to us, we usually put clinical officers in such posts. So I want to understand, is it the same with Rwanda, the model that you're talking?
Yeah, thank you very much. That's a very good question, by the way. So community health workers do not work at the health post, but they work in the communities. They work at the household level, and they are not necessarily like maybe trained nurses. They are people with basic education who can read and write, and then they are given specific training, not academic training, but really hands-on training. So they are able to support the communities, the households, and then severe cases based on their training are referred to the health post. Now, at the health post, it is headed by a nurse, a qualified, certified nurse, and other certified healthcare workers, except, of course, for the receptionist and the stock management. They are, of course, also very certified, but not in a clinical aspect. So it is interlinked. Community health workers manage education, and they are able to treat simple cases and then refer to the health post and the health center. So it is an interconnected community system.
So majority of people, of health professionals working in the health post are nurses?
Yes. Yes.
Barnabas or the other panelists, do you guys want to add to that? Because I know, at least for Tara, I know there's certainly interconnectedness with community health workers or even nurses, or what you saw. Anybody want to jump in?
Yeah, I think it's just also important to highlight that the nurses that are working at the health post, most of them also have received business training, and they're in the process of also ensuring that everyone has received that entrepreneur training, so that they're able to also maintain and act as also like running a business in addition to being a nurse, so that they're able to maintain the health post alone and work with. I know that there's also normally a pharmacist, and normally there's like a lab tech that's working at the health post as well. So and they also manage all the salaries and all that. That is all solely the nurse entrepreneur. So I think it's important to highlight that as well.
Wow, good. Barnabas or Dr. Stevenson? Yeah, good. Let me take one online, and then I see you, Gavin. This is maybe you see your hand, which this I think might tee you up. Maybe what you're interested in. We have great questions of how do you keep local and state government partners on board throughout implementation, and then the sustainability issue of how do you do that, maybe with working with government partners, implementation throughout. How have you done it?
Yeah, at Society for Family Health, we pride in partnerships. We believe that no single institution, no single person, no single organization can do it alone. In fact, as a matter of principle, because of our belief in partnerships, we signed an agreement with the government of Rwanda, a public-private partnership for 15 years to support the transformation of primary health care. And in implementing that, we have enlisted different partners. For example, technology partners, for example, different donors, for example, other individuals with skills. So they come in, we come together and build a consensus on how to do it. One of the things that makes me happy to be at Duke today is that maybe we can also have a partnership around research and evidence generation, which we can use to improve. So really, it is a continuous journey of partnerships, looking at what works, what doesn't work, and then building a consensus of how to improve.
Excellent. And I see where Barnabas wants to jump in too. Can you talk about partnership between UGHE and SFH?
I think that the key thing to understand, everybody working within Rwanda is working in partnership. Things are not done in isolation. The government actually has streamlined things such that there are no silos, as it were. So there's always some form of cross-cutting. So where SFH, for instance, is working to put in the health posts and ambulances, etc., University of Global Health Equity is doing some community-based education in partnership with local communities. And some of the places that we do visit are these health posts that have been set up. So in that manner, there's a way that things are streamlined, and there is always a cross-cutting. It was Paul Farmer that said that some of the best things you will ever do in life will be done in partnerships. So I think that within the framework of the bigger system, as project implementers, SFH, they're providing spaces for UGHE to be able to take learners to do community-based education and social medicine, really.
All things in partnership. Thank you, Barnabas. All right, Gavin.
Thank you very much, Gavin Yang. I'm a DJ on Duke College Radio, but also a professor of global health here in my spare time. And also absolutely honored and delighted that our Center for Policy Impact of Global Health are hosting Manasa for the next month. Manasa brought us some extraordinary coffee from Rwanda, and in return, we've given him Trent Hall coffee. So it's been a bit of an imbalance, but so my question is about one of your slides said something exceptionally important. WHO estimates that there will be a 40% decline, really massive drop in DAH, in Development Assistance for Health, Aid for Health, baseline of 2023 to the end of 2025. In one of your slides, in quite small print, you said you are not going to need to rely on donors, right? You're going to have a sustainable financial model. And I think that was referring to the nurse-led entrepreneurship. Can you tell us just a little bit more about that? Is it that a nurse runs the health post, and then if it's profitable, the nurse keeps the profits? Or how does that entrepreneurship work?
One thing I must provide a caveat. When I talk about this, I get animated. So I'll try to keep it the context of your question.
No, you can go for it. Let your freak flag fly.
Yes.
You know, I think because we kind of stumbled into this model, we are so excited about it.
Yeah.
Because for too long, the health sector has been referred to as an expense and a consuming sector.
Yeah.
I think in quotes, non-economic sector, even if it is really providing healthcare to people who are producing other things. So, but in Rwanda, we have realized that at the lowest level of the community, you can have a health facility run by a nurse who is an entrepreneur. And once you have just sat there and given them the right tools, skills, and support, it is absolutely sustainable. So, simply put, instead of pumping money all the time in terms of salaries and all that, in a functioning system, a nurse will have that facility as their own, as their micro business, as long as they are able to provide exactly prescribed services in the service package. And all the revenues are their money. All the expenses are their expenses. All the profits are their profits, as long as they're delivering a service. One that you, Gavin, and Sundu visited, and Maggie, they saw that the nurse does not look at this facility as a job. It is more of passion. because they are doing exactly what they started to do, but they are making money. On top of the salary, they have also profits. So to us, we believe that if we roll this across the African continent, the animation side of things I talked about is, I imagine if we have 100,000, and we did an estimate that 100,000 of these interconnected, supported with right digital tools will solve the problem of healthcare once and for all. And that decade we talked about is going to be history if we support and work together. Thank you.
What a way to, yeah. Gosh, sadly, we are out of time. I think we could stay forever. What a way to launch the Think Global this semester. It feels encouraging and inspiring. And, you know, we hear these words, sustainability, interconnectedness, and partnership, and we all say yes, but to see it done on the ground and to hear about it is just really inspiring. We all have mountains to climb, but we also don't want to miss the beauty of those mountains. And I think you said that beautifully today with partnership. So thank you so much for joining us. Someone online also said that their grandparents' house was converted into a health post after the genocide. Oh. So it's heartening to see all this important related work, and for sure. Thank you to the panelists for coming and sharing your expertise and thoughts, and everybody have a great day. Thank you. Thank you.